Good morning, all. And outset, I would like to thank our Holiday Society and Scientific Committee for this opportunity. My talk is on why thigh angle and anti-chamber. So, why angle and anti-chamber is so important? Because although open angle glaucoma population of open angle glaucoma is much more than angle closer glaucoma, but ratio of blindness is 1:1. Primary angle closer glaucoma carries threefold risk of severe blindness rather than open angle glaucoma. So, which type of glaucoma is related with the angles? Lot of like primary angle closure, neovascular, lens induced, traumatic, pigmentary. We have to do how to watch this our angle. So subjective method, objective method. First focus about the subjective method, that is von Herrick and gonioscopy. So this is a von Herrick test. Limbal chamber depth as a fraction of corneal thickness. It is a semi-quantitative test, gives suboptimal result, hardly reproducible. Second one is a gonioscopy, that is the indirect one. It is the most common, and gonioscopy will tell about all angle grading to iris configuration, deposits of synechiae or pigments, vessels, and it is the most critical instrument, and you can tell that it is an open angle or closed angle. It is tell that why this is a complete angle closure, not it is an open angle, because of corneal wedge. You can tell about with the gonioscopy the strab ostium is patent or not, thick anteriorly placed lens, or any irregular arborization of vessels crossing scleral spur, it is a new vessels or not, pigment dispersion syndrome. With the gonioscopy, you can do dynamic assessment and will have a better understanding of pathology, and you can observe likely effect of PI or any procedure. But gonioscopy has many limitations like observer dependent, lighting, 2-3 type lenses. Documentation is a very big limitation, skill and expertise. This limitation will overcome by UBM. It will give a high resolution of 50 micron, and it is independent of corneal opacity, and dynamic changes can be recorded. And this is the UBM scan orientation. So UBM has a role in glaucoma. It can image iris ciliary complex. It can refine our concept and modify our therapy in like this aqueous misdirection syndrome. In plateau iris, you can see there is an anteriorly directed ciliary process. Then you can confirm plateau iris. In this case, lens-induced angle closure, you can see the phacomorphic lens clearly visible by this method, but has a limitation. Angles open up supine position, only one quadrant imaging, need a skilled examiner, and it cannot detect pigmentation, neovascularization, and inflammatory exudates. Next comes the ASOCT. Its interpretation depends location of scleral spur and curvature change appear as an invert protruding sclera. So, but it will give 45% false positive. We still need to do a gonioscopy. So, advantage of ASOCT is a high resolution, non-contact method, all 4 quadrants at same time, sitting position, entire cross section in one frame, ancillary body not imaged fully. This is the limitation. Eyelid obstruction. So both had a similar, but ASOCT has a ease of operation, sitting position, no distraction of globe. Newer imagings are coming like this CASIA SSOCT. It can clearly tell about the close angle iridotrabecular contact index. And right one is the HD OCT, clearly visible Schwab's line. So here is we can conclude here, expensive technique versus gonioscopy. What we see in gonioscopy is actual image, rather than expensive technology. So newer technology or expensive one can't do dynamic assessments and missing core information like cyanic is unable to tell it is primary or secondary pathology, missing minute detail like pattern of pigmentation, and limited to narrow section scan. Like you can see in the image, if section is right, that blue line, definitely it will miss PAS. So here we can conclude that UBM and AIOCT provide real-time cross-sectional image, but accuracy and reproducibility yet to be proved. We can document easily, but gonioscopies continue to be crucial, essential for evaluation and management. Thank you. First preference gonioscopy, then AIOCT.
So I think almost always the gonioscopy is the most crucial thing that a glaucoma specialist or any person treating glaucoma should master, and most of the things I think we can detect by skill and experience. Only in situations like you have already mentioned, confirm malignant glaucoma, ciliary body cyst, ciliary body tumor, then probably we can take help of the UBM. Otherwise, regular gonioscopy will detect most of the conditions for glaucoma.
Thank you. That means the gonioscopy is part and parcel of our examination. It is nothing different. So the way we are doing an applanation slit lamp, we should do gonioscopy in our all glaucoma cases. Thank you so much.